Welcome to Bear in Mind, the Brown Psychiatry Podcast, clear, current content about mental health. I'm the host, Dr. Tracey Guthrie, Psychiatry Residency Program Director and Co-Editor-in-Chief.
I'm the co-host, Dr. Camila Cosmo, Brown Assistant Professor and Co-Editor-in-Chief.
And I'm Dr. Nisha, Jain, Psychiatry Resident and Script Editor for today's episode.
And I'm Dr. Curt LaFrance, the guest on today's episode.
Great. First, a content warning.
In this episode, we will talk about sensitive topics, some of which you may find triggering. Our only purpose is to provide education and information. Our content is not to be considered medical advice. Functional Neurological Symptom Disorder, FND for short, sometimes referred to as conversion disorders in the past, are neuropsychiatric conditions that cause patients to experience a wide range of symptoms from non-epileptic seizures to complete loss of their ability to speak, walk, or function on their own.
So far, the mechanism is poorly understood, and there are no lab markers or imaging techniques that can confirm this diagnosis. In addition, treatments and interventions are still scarce. Approximately 4 to 12 per 100,000 people develop a functional neurologic symptom disorder per year.
Dr. Curt LaFrance joins us today to discuss functional neurological symptom disorders. Double-boarded in psychiatry and neurology, he directs the neuropsychiatry and behavioral neurology program at Rhode Island Hospital and the VA Mind-Brain program. With extensive experience diagnosing and treating FND and other neuropsychiatric conditions, Dr. LaFrance is a leading expert in the field. Welcome, Dr. LaFrance. It's a pleasure to have you.
Thank you. It's great to be here.
Thank you.
Dr. LaFrance, what is the current definition of functional neurological symptom disorders, and what are some risk factors for developing it?
There's the definition from the diagnosis book that we use in medicine, and it describes FND, or conversion disorder, as you mentioned, as one or more symptoms that affect bodily movement or your senses, and symptoms can't be explained by neurological or other medical conditions. Symptoms are not consciously produced, and they're not faking the symptoms. I was asked to be an advisor on the DSM-5, the updated version of that book. And one of the things we wanted to do was to make sure that clinicians could rule in the diagnosis, could make the diagnosis definitively. So we added physical signs on exam to be able to do that. Before that, we could only guess or hedge, but now we've got a good, strong way to make the diagnosis. I view the brain and the mind as two sides to one coin. So the way that I explain the diagnosis to my patients and to families is that FND, or CD, conversion disorder, is a neurological presentation of an underlying psychological conflict or stressor, like life events that happen. And it's also a behavioral expression of brain circuit dysfunction. So it's both and. Some of the risk factors include psychological and social and biological factors. They all can contribute to developing FND. And we call these predisposing factors. Other factors may precipitate or may prompt the onset of a symptom. Also, there are adverse life events where sometimes, like a loss or an injury or a history of trauma or abuse, those chronic stressors can also produce symptoms.
So, is it possible to have both a structural neurological condition like epilepsy, multiple sclerosis, and functional neurological symptom disorder at the same time? And if so, how often do these conditions occur together?
Yes, patients can have both neurologic and psychiatric disorders. They co-occur many times. One of the ways that we assess somebody if they do have both is we'll bring them into the monitoring unit. And when we do that, we'll find up to 10% of people who have non-epileptic seizures also have epilepsy. Similarly, in the movement disorders world, we'll find that up to 7% of patients who have Parkinson's disease can also have a functional movement disorder.
So, can you tell us a little bit more about the type of patient that will come and see you and what kind of symptoms they're typically having?
Sure. So I have a clinic at Rhode Island Hospital where I see civilians, and I have a clinic at the Veterans Administration where I see veterans. And the patients with FND and conversion disorder look like you and me. What happens, though, is that sometimes they will present with an inability to move their arm, or difficulty with walking, or sometimes they'll have a new onset tremor that looks like Parkinson's, but it's not. Or they'll have had seizures that looks like epilepsy, but it's not.
What are some of the most common presentations of FND?
Any way that neurological presentation can present, a functional neurological disorder can present. So I'll have people who come in and they have seizures. When we hook them up to the electrodes to do a monitoring in the monitoring unit, we'll find that there are no abnormal brain cell firing going on. That's a non-epileptic seizure as opposed to epileptic seizures. So it can look like epilepsy. Another is that somebody could come in with a weakness on one side of the body, and interestingly, when we do the neuroimaging and we do the exam, there's no stroke or tumor. And it turns out that that was a movement disorder or a motor FND presentation.
So we were talking about that this is not something that is consciously, done by the person experiencing these symptoms. But what do you say to people who say or who believe that people with FND are faking it?
We were intentional about trying to change the language. So when we were doing residency together, there was a term pseudo seizures that was used, as you may recall. So pseudo, as you know, means false or fake. These aren't fake seizures. They're real seizures. They're just not caused by abnormal brain cell firing. So I try and encourage people during residency in the literature and in research, whenever we would see pseudo seizures, we would strike it in the editorial. When we were editing the manuscripts, and we were intentional about putting in non-epileptic seizures. I tell people that the large majority of people who come in, this is an unconscious process. They're not faking it. There's a small subset of people, maybe less than 5%, who are actually faking it. But that's a different population. That's people who are trying to get out of jail. That's people who are trying to get out of military service. That's people who are trying to get extra money out of the system. But there's a profile in those patients that differs from the people who are coming in with conversion disorder.
And what makes FND so hard to diagnose and treat? And what are the currently available treatment options?
Well, one of the things that made it hard to diagnose is because of the diagnostic criteria that we were talking about earlier. Before, you had to show that there had been a past trauma or an adverse event in somebody's life. Here's the problem. You're in the emergency room and you've presented with seizures or a weakness, and the doctor comes down and you speak for about 30 minutes. You don't know this person. And so you might not open up. You might not kind of divulge that, well, this thing happened a while ago. So we couldn't definitively make the diagnosis because we didn't have that one criterion that was needed to make the diagnosis with the old way. We kept that in as an important factor, but now it's a note in the diagnosis. So what we did is we acknowledged that people have had histories in the past, many of them, not everybody, but now we use diagnostic signs such as specific signs that we use on the exam to help rule it in. So it's actually easier to make the diagnosis more definitively now with the new criteria. Regarding treatments, the good news is that we've got evidence-based treatments that have occurred that we've been able to conduct trials over the past 20 years. And so now people are getting better with these new treatments.
Can you give us some examples of what are some of those signs that you observed during the exam?
Sure. So for movement disorders, there's a sign called entrainment. And entrainment occurs when somebody has a tremor, and then we ask the person to follow our movements as we're demonstrating them. What we might find is a tremor that starts at one frequency actually might start to entrain into the same frequency of the movement that they're making with the other hand. Now, one thing to note is that with our with our exam, we're not trying to trick a patient. We're trying to document an exam. And this is one of the ways when we document this, we can also show it back to the patient. And we can say, did you see how your tremor changed? And that provides insight for the patient that, hey, you know what, it might not be due to Parkinson's or to a brain tumor.
Are there any recent research studies with promising findings on future treatments for FND?
There are a number that are out there. So in our prior studies, we had shown that people who used a workbook that we developed, that we saw a reduction in their seizures, their non-epileptic seizures. Many times people also have co-occurring symptoms and diagnoses like depression or anxiety or post-traumatic stress disorder, PTSD. We found a reduction in those. We also found an increase in their quality of life and in their functioning. That was in the prior studies. What we've done with our more recent research is using that same workbook. It's called Taking Control of Your Seizures Workbook. It's published by Oxford University Press. People use it all around the world. Now what we did is we wanted to look at mechanisms, not just the effect of the treatment, but also what's going on in the brain. And so we did imaging before and after people received neurobehavioral therapy. And we found brain changes. We found what we call neuroplasticity. There were more connections and there was increased size of brain regions after receiving neurobehavioral therapy.
Very cool. So I can imagine that someone who has weakness in an arm, they go to see their primary care doctor, and the primary care doctor will order will do an exam, order some tests, and they didn't find anything that specifically is causal, that has caused this issue. And then they may go to see their primary care doctor again, or they may go to a specialist now. So it takes a while for someone to be able to get to you, would be my guess, to be able to get to what is this diagnosis that's happening. So the experience of a patient is not that they get to see someone who has the expertise like you do right away. This is something that someone starts with a symptom, they don't know what it is, they see their primary care doctor can't find a cause for it, they send them to a specialist maybe on the area of interest, so if it's a seizure, to a neurologist, if it's a motor problem, a problem with moving your body, they may send them to someone who specializes in movement disorders. If it's a speech problem, they may be seeing somebody else. And then someone eventually says, I think that some of these issues may be caused from a different cause. And you should go see maybe Dr. LaFrance. So it takes a while for people to get to see you. Is that a fair summary of what happens?
It is fair. In the past, I will say that times are changing. One of the ways that's happening is with education, not unlike what y'all are doing here with the podcast. Education is not just at medical conferences. So I and my colleagues will speak around the country and around the world and at different medical schools, and we'll give grand rounds or talks each week on this topic. So now primary care doctors are learning about it. Emergency department physicians are learning about it. Pediatricians are learning about it. So more on the front lines, not till the time that you get to the specialist or the subspecialist. Education is making a big impact both in clinical realm and also for our patients and their families.
And what is the response of patients? What's your experience of the response that patients have when they're told, I think you have a functional neurological disorder?
It depends largely on the presentation of the diagnosis. So my approach is to and this is what I learned here in residency and in medical school, I try and treat the whole patient. So I want to hear the whole story. I don't want somebody to just come in and say, oh, they can't move their arm, got an MRI, no lesion, therefore you have a disorder, done and you can go.
Right.
I want to hear your story from the beginning. Also, when people get referred to me, I usually have all of the records from the prior 7 evaluations that you mentioned. So there are 3 MRIs, their brain imaging, and their 6 EEGs, the electroencephalography, and also their cardiac workup for their heart when they were fainting. I get all that information. I go through that. And then I sit with the patient and the family for a few hours, actually, to hear the story. When I've heard the story, when I've done the exam, when I have gone through the labs, the extensive lab work, then at that point, I feed back to the patient and the family member the story that they told me. And I let them know. I say, here's what I heard and here's what I've learned about you. And then we'll start from the beginning, and in a concise manner, I'll tell them that story back. And I'll say, now let me know if I've got any of this wrong. You can correct me so that I've got the story right. After they know that I've seen and heard them, then I'm able to say, based on this information, my opinion is that you have conversion disorder or functional neurological disorder or non-epileptic seizures. The good news is that we see this all the time. It's very common, actually. And the really good news is that we've got treatment available. And if that's something you're interested in, we're happy to set you up. And so people are more receptive in that regard.
Sure.
If you get the very brief, I know what you've got, diagnose and adios sometimes, then unfortunately people aren't as receptive, I've seen.
And when you discuss within the diagnosis, do you recommend any books, any resource? Is there anything that you advise them to look further, to learn better about what they are going through?
There are plenty of books and resources that are out there, both written hard copy, but also on the internet. Whereas when we were in residency, there wasn't as much. You can find it in textbooks, but as far as what's available for patients and families, much more limited. Now, bunch of literature all over. So I'll recommend a few things. If you have seizures, I recommend looking on the American Epilepsy Society website or the Epilepsy Foundation of America website. And there are fact pages there for patients and for clinicians. If you have a motor functional neurological disorder, I recommend going to the Movement Disorder Society. And there are fact sheets on movement disorders there for people. If you have, if you're a veteran, the VA has a number of resources for patients, whether it's the VA Epilepsy Centers of Excellence, or whether it is the VA Mind-Brain Program, which you mentioned that I direct, and we're training people around the country to be able to help veterans with this disorder. And then lastly, there are treatment resources. There's the workbook that I mentioned from Oxford University Press, Taking Control of Your Seizures workbook. And there's also, that's what you use that with a clinician. But if you want to do self-help, there are also self-help resources out there. So neurosymptoms.org is very helpful to a lot of people around the world.
So, Dr. LaFrance, you were mentioning that sometimes there's one of the possible or risk factors is someone who has a history of trauma. But in medicine and also for people or lay people, they also think about something that's happened being causal. So something would have just happened and then these symptoms occurred. But sometimes that's not the case. Sometimes whatever has happened a year ago, 10 years ago, 15 years ago, 20 years ago. And then I wonder if you could speak to this timeline, how we should think about it differently to when symptoms manifest and what we mean by a history of trauma.
It's a question that gets asked a lot. And the way that I explain it is the 3 Ps, which is predisposing factors, precipitating events, and perpetuating factors. And those are basically words that just describe predisposing mean the way that you might have been raised or experiences you had when you were younger. And a precipitating event is something that happens acutely, like right now. I had a car wreck yesterday and now I can't move my arm. And then perpetuating factors are, what kind of environment are you in and the things that you're dealing with in life? I'm out of work now and I feel badly about myself because I can't provide for my family. And that's a perpetuating factor. Those are part of what we call the causal pie. And that causal pie, each of those may be a contributor to the presentation. So when people say, yeah, but it happened 20 years ago, how's it related? And my response to that is mesothelioma. And so you think about it. Here's a person, and in fact, one of my best friends who is deceased now, he ended up getting diagnosed with mesothelioma in 2017. Now, that is a type of tumor that grows in the chest, and it basically cuts off circulation and breathing, and it ends up killing the person. In 2017, when they were doing the workup, they said, well, what exposure did you have? And he said, well, when I was a teenager, I spent a summer hanging insulation, 18 years old, exposed to an agent, asbestos, that ends up setting up a latent process, a process that can lie under the surface. And then in his 60s, he ends up developing this tumor in his chest that killed him 2 years later. That's mesothelioma from an exposure many years ago. That's a physical example of what we talk about with a history of prior trauma or something that happened, a major loss, a parent died at an important developmental stage for the person. And then later on, that's one of the causal pi factors, not the only one, that ends up later resulting in a functional neurological disorder. That's how I explain it.
Yeah, I think that's very helpful. Yeah.
So we can imagine that for some people might be hard to face a diagnosis of FND. And I'm wondering, how do you explain that to them? How do you discuss treatment? And why it's so hard to treat FND?
Why is it so hard to treat? I think that one of the biggest factors that makes it hard to treat is the divide between neurology and psychiatry. We have separated out in medicine brain and mind, where really it's two sides to one coin. When somebody has a symptom, they want a pill to fix it. And everybody wants the magic bullet. In functional neurological disorders, there's no magic bullet. We don't have a pill that makes everything go away. And so I don't promise that to people. So one of the first studies that I conducted after finishing the combined residency in neurology and psychiatry here in a research fellowship was an NIH-funded trial where we actually did give a medication. And that medication showed a 45% reduction in seizures in the people who got the serotonin agent, the brain chemical medication. And then there was an 8% increase in patients who got the sugar pill, the placebo pill. It didn't cure. It didn't make everything go away. There was some help to it, but there wasn't a magic bullet for that. So after that, we started developing therapies, a psychotherapy. So when you ask, so that's one of the reasons that it's hard to treat, is that we don't have a magic bullet. And anti-seizure medications, anti-epileptic drugs, don't treat this disorder.
Indeed.
So that's what makes it hard. That's what makes it hard. Another piece is that when people fall between neurology and psychiatry, I call that the borderlands. And when people are in the borderlands, that's where those long time seeing different doctor after different doctor, different emergency department. When people look at it from a combined neurologic and psychiatric perspective, brain and mind, that's where people can lessen that time, and they can actually get the treatment that they need. Regarding treatments. So what we did after the medication studies is that we developed what's called a multimodality, which means different types of therapy. We combine them all into one treatment. And the way that we did that, when I was in residence here, we have a lot of exposure to good psychotherapy. So as you probably know, Sigmund Freud, he was a neurologist, and he developed psychoanalysis, which later on became psychodynamic psychotherapy. So trained in some of that here. And then also a person by the name of Aaron Beck. He was a psychiatrist who developed cognitive behavioral therapy. Over time, in supervision, I realized there's not one best psychotherapy. So what we did as a neurologist and psychiatrist, I thought, what about combining the best of all the different therapies so that you have targeted treatment for the known challenges in the patients, and put it in a 12 session, one session per week, workbook. The patient takes the workbook, fills in each chapter. The patient does the work. And then they bring that in and talks through the work that they've done, getting these new skills and tools from the different modalities, the different types of therapies. They apply it to their lives. And then the therapist or the counselor who's walking with them, they end up trying to assist in any way, but they don't do the work for the patient. That's the treatment that's shown the biggest effect, and that's the typical treatment that we'll offer to people.
Mm-hmm. In your experience, what is the remission rate after those 12 weeks? How successful is the treatment?
So 12 sessions doesn't mean 12 weeks. Because life happens. Sometimes the car broke down on the way to the appointment, or if you're doing telehealth, then you can't get connected on your internet. So for some people, even though it's 12 sessions, it may be 24 weeks. It may be a little bit, but it's designed to be delivered weekly. So you kind of keep things together. People who have used it for seizures, about half of people at the end of treatment have no more seizures. I don't use that as the gauge of effectiveness, however. And here's the reason why. We heal very little in medicine. Indeed. We treat a lot. We don't heal much. Think about chronic migraines. Think about diabetes. Think about asthma. So people, instead of saying, I'm going to take away all of your symptoms, which I don't even have the power to do anyway, I tell people, we're going to equip you so that you're able to use these skills and tools and you can live a better life. So even if you do have another seizure, or even if you do have a little trip with your leg, you can still have improved quality of life. You can still have good functioning. You can still go to your kid's baseball game. So I don't look at 100% remission. I look at improvement in quality of life and functioning.
Makes sense.
What would you recommend to someone struggling with FND who hasn't found the right care just yet?
I would say keep looking. And here's what I mean by that. There are people all around the country and now people all around the world who have been equipped and trained to recognize, to diagnose, and to treat people with FND and conversion disorder. In the past, yes, there were a few centers here and there, Brown being one of them. Now we've really made an effort with the education that we talked about to try and spread the wealth, if you will. And we want people to be able to go to a doctor who says, I'm comfortable and familiar with this. I see this all the time. And you know what? We've got good treatment, and we're happy to offer that to you. And by the way, for your tremor and your gait or your walking disorder, we've got great physical therapists and occupational therapists and speech therapists who can help you with the symptoms that you present with. And we work together. We call it multidisciplinary treatment, where we're working together for your benefit. And those are being developed and popping up more and more now around the country. It might take some effort, but I'd say keep looking.
You talked about using different modalities of therapy, bringing together the best of things. Yeah. In your experience, is there a type of therapy that doesn't work for people with FND?
The therapy that I have, so let me answer that by, in our studies, we do a deep assessment, an extensive assessment of everybody who comes into our treatment studies. And one of the questions we ask is, what treatments have you had already? 60% of the people who come and enroll in our studies have had prior therapy. So that means, and they're still having symptoms,
right,
which is why they're coming to see us. So that means that therapy didn't help.
Right.
So to answer your question, of those people who've had prior therapies, the ones that report the type of therapy mostly is supportive psychotherapy.
Right. Right.
So I know that it has helped with some people, and I don't mean to disparage supportive psychotherapy, but when I see people who've 60% have had supportive psychotherapy and they are coming to me because they're still symptomatic, that's telling me that one for this disorder might not be helpful.
Right. Correct.
So let's do something to equip you with tools and skills.
Right.
And then let's let you be able to, you are taking control. You're the one who's implementing these, and you're the one who is applying these to your life so that now you're not depending on the therapist to fix you.
And depending on the therapy and the therapist, sometimes those things these symptoms get more entrenched.
Yes. So as I mentioned, in neurobehavioral therapy, we've taken elements of each of the therapies. In session 6 on relaxation, we use cognitive behavioral therapy techniques. Cognitive behavioral therapy is a type of therapy, again, brought forth by psychiatrist Aaron T. Beck. And it's where you look at cognitions or your thoughts, affect or your emotions, and your behaviors. And you find the relationship between those. Certain patterns of thinking that we have are not very helpful. And the term for that is maladaptive patterns. And basically we help people to identify, I'm thinking that way again. It's not helping me. Mm-hmm. Here are some ways to get around that unhelpful thinking. That's one example. Mm-hmm. Another example, and we'll teach relaxation techniques that are taught in cognitive behavioral therapy. Another approach is what's called interpersonal therapy, and that's how we interact with each other as human beings. Mm-hmm. And so for interpersonal therapy, in session 2, we teach about healthy communication. Do you use unhealthy passive communication or unhealthy aggressive communication, or do you use healthy assertive communication? So we teach those techniques, mm-hmm. another skill or tool that a patient can use from interpersonal therapy. Another example is, I mentioned earlier, psychodynamic psychotherapy. That was the one from the neurologist Sigmund Freud, with analysis modified to psychodynamic. This is an interesting thing. You asked about the history or the past. Mm-hmm. We take what happened in what we say the then and there, and we associate it with the here and now. Mm-hmm. Mm-hmm. So we make what's under the surface, we bring it to the surface. We make what's unconscious conscious or known. And that's when people make that link, and they're reacting to something that happened in the past, then they have the tools to break those links, mm-hmm. and they don't have to react to them in the past. So mm-hmm. a number of different therapies.
So, I mean, I think that's extremely helpful. I think the other thing that's extremely important to say is the person doing this therapy is skilled to know when to do this, when to bring up these conversations, when to reflect on this, and also is challenging you and educating you, not just passively listening to you. They are very active in the therapy. So therapy is not therapy, I think is a very important conversation for us to have around FND, but also around many other disorders. Mm-hmm. But FND certainly does raise its importance because it is one of the primary treatment mm-hmm. options that is going to help people get control back of their life, as you're saying.
And that's why for people we've got a couple of options for training. Mm-hmm. For neurobehavioral therapy, the multimodal therapy that I mentioned, the whole person integrative approach, it's not just doing a task, it's a way of thinking.
Right.
And so the way that I was trained in medical school was with a whole person approach, which is biopsychosocial spiritual. It's looking at the whole person of who they are in the context of who they are in their humanity. And so to look at it from that frame, then I realize, yes, biologically, there might be some anatomic or some parts of the body that are affected. Psychological, there may be some moods or feelings that you're having. Social, some of your interactions with your family and friends. And then spiritual, some what we call existential, some big picture questions that you're struggling with. We look at all of those. That's integrated into the neurobehavioral therapy. When we do that, we train people around the country to be able to take that framework, to use the workbook, and in session 2 you do this, and in session 3 you do this, and in session 3 is psychoeducation, mm-hmm. where we teach them about what medications do or don't help.
Right.
So the people who are being trained are learning as much as the patient is learning.
Mm-hmm. Correct. It's all about the learning or unlearning.
Yeah.
Unlearning
Yes.
a lot of previously held thoughts, beliefs that keep people stuck. I think that's wonderful. So FND doesn't just impact the individual. If you are someone who has a functional neurological disorder and you're having seizures, you may not be able to work. You may not be able to care for your kids. You may not be able to be as involved. You may be in the hospital. if you're unable to walk, or you have a motor problem of some other type, same issues may impact you and your family. So how can family members who are struggling with this, how can they support those people who are suffering from FND? What can they do? Because it's impacting them greatly as well.
You're identifying a very important point. No person is an island. We exist in a social context, and we were not made to be alone. We exist in community. So sometimes people will come to me for the consult, and they'll say, they told me you're the only one who can help me.
Right.
And I'll say immediately, I'll let people know I don't have the power to make you better. I can't do that. What my role is to walk with you as you do the work. I call that abiding with the patient. And that's meeting the patient where they are and walking with them the next step forward. So I'll tell people I'm part of the treatment team, but I'm not the main one. I'm not the only one. And I'll let people know you've got family and friends who are supports. And we try and help them to go from, we see different patterns in interactions with people. There's codependency, which is I can't make a decision on my own without you. That's on one extreme. On the other extreme is independence. I'm not going to ask anybody for help.
Right.
What we try and do is get people to the middle, which is interdependence. I'm going to try and do it on my own, and if I can't, then I'm going to ask for help from a supportive person. That's where we try and get them with family and friends. The other place that's important is that people sometimes they'll look to family and friends. They'll also look to their community of faith. That can help with some of the bigger pictures and dealing with pain and suffering and losses. It provides hope to people beyond what the world has to offer many times. So I tell people, along with your doctors, part of your treatment team is family, friends, and faith.
So Dr. LaFrance, we've been talking a lot about the treatments that are available for FND and conversion disorder. And I think something that might pop into people's heads is, are you telling me that this is all in my mind? Is this all in my head? Is it not real? And I guess also, with all the therapies, the other question might be, well, how is relaxation going to help the fact that, I can't move my leg? And so how would you respond to those questions?
Yeah, and those are questions that get asked a lot by patients. So valid questions. When somebody will say those exact words, so are you saying it's all in my head? Then I'll respond back with, if you mean, am I just making this up? No, that's not what I think. And then I'll go back and I'll tell them the story again, of the narrative that they gave me so that I understood them. So, and they can correct me. And then what I'll do is I'll say, this is very common in people who come to see me. I see people from all over, and your story is unique because it happened to you, but it's common amongst people with FND and conversion disorder. So it's not unique in that respect. I'll tell them that as I explained to people, it's a neurological presentation of an underlying psychological conflict or stressor, and it's also abnormal brain connectivity or connections between circuits in the brain. And so it's both and. It's mind and brain. And the way that we help with those symptoms is by taking the then and there and then associating it with the here and now, helping them to make the links. Then they use these therapies to break those links. I've got an example of some people who have been overseas, and some things happened when they were in combat, and they feel very badly about them. And there's a condition called moral injury. Moral injury is when somebody either carries out or witnesses an event that goes against their conscience and their moral code. And that can have significant effects. It's different than post-traumatic stress disorder. Sometimes it can be seen with. And after somebody tells me Doctor, I think I'm a monster. My response is, I don't have an anti-monster pill. I don't have a pill that's going to fix that. But what we can do is with some therapies and with addressing the spiritual element of that, sometimes with meeting with a chaplain or talking through these violations of a moral code internally, sometimes with forgiveness. That's where the healing happens. So that's where I try and make it, we're not going to be able to cut this out. There's not a portion of your brain and there's not a pill that's going to fix all these symptoms. That hopefully helps to make a bridge between sometimes therapies can help. I won't say that relaxing is going to make everything go away. I know a lot of people are using mindfulness. In one of the sessions, we have some mindfulness techniques, but just being mindful is not going to fix this issue. You've got to get to the core, and some of the tools and techniques that we use help the person get to the core, to go to those hard places, to be able to look into that abyss. We walk with them up to that point. We don't push them in, but we're with them in those hard places. That's where therapy can really help.
You know, in the way you're describing things, the other things that we see in treatment is a lot of these things are secretive. They're hidden. They're things that you carry by yourself. You haven't talked to anybody about. You haven't shared with anybody. And that has a cost. So I think that it's another helpful way of thinking. It's a scar somewhere, and it can cause a short circuit. It can cause a problem. And secrets are generally not good for us, our psyche, our body, our mind, our spirit. And we need a place to be able to safely divulge those for healing to occur. So to the question of, you know, how is this going to help me stop my tremor? It may be that you've got something you've got to share, something you want to talk about, something you had a feeling about, something that you did, something that happened to you, something you witnessed that may have left a mark on you that you may not be aware of.
And sometimes when we've seen or experienced some difficult things, sometimes the body protects the mind.
Correct.
And so these physical symptoms can manifest themselves not intentionally, but as a distractor to, I don't have to focus on this hard thing if everybody's focusing on the tremor.
Everybody's focusing on the tremor, right.
When people come to the clinic, I'll let them know at the outset, there are no taboo topics in this clinic. And so whereas some people will come in with the unspoken dilemma, I'll let them know, you can talk. It's fine. With a non-judgmental attitude, with a non-pejorative attitude or punishing attitude, with a compassionate approach, that's where people do have that safe place that you're talking about to talk about race and politics and sex and money and religion and all those things that you can't talk about in polite conversation.
Right.
But boy, we can talk about it here, and that's okay.
And probably needed to talk about.
Yeah.
Well, how would you treat somebody if they're not able to talk, that their FND does not allow them to talk?
I've described in my writings and in my research that conversion disorder and FND is a disorder of communication. And so in neurology, we have something called an aphasia, or an inability. It affects your language. And sometimes we can have mutism, where you literally cannot make a sound. And it's not that kind of communication disorder. Aphasia is seen in strokes and in head injuries and dementias. This is a disconnect where somebody, for whatever reason, growing up, they have an inability to express distress in a healthy verbal manner. So part of the tools that we use in the therapy is helping to develop that expression. So I've had some people who can't speak, and I'll say, do what you need to do to express yourself. If you need to write it out, that's fine. If you need to draw it out, that's fine. Whatever it needs. But there needs to be some type of expression to overcome that communication disorder.
I can imagine that there are situations that may arise that you may have come across in your clinical practice where people say, listen, I know I've been to all these different specialists, and I'm now seeing you as another specialist, but I firmly believe there's something else wrong with me that is so rare, is so hard to diagnose. People just don't understand it, that they just don't know what it is that I have. And maybe it's FND, maybe it's not, but I think I must continue to advocate for myself, I must continue to pursue a line to be able to find the true diagnosis, because I don't necessarily firmly believe that it's FND at this time.
When I face that situation, and that does happen, I think back to some of the principles that I learned from my mentors, and one of them is approach every person in diagnosis with humility. That's important. There may be something that I haven't seen. There may be a rare disease that I'm not aware of. Absolutely. The way that I try and approach the patient in that situation is from reviewing the past 7 doctors' notes who you saw and their extensive workup, and from spending a couple of hours with you and hearing your story. My opinion is this. My job is not to try and convince you or make you believe what it is. If you want, feel free to go see another person and get their opinion too. I'm happy to talk with them, or they can have my notes and they can agree or disagree with that. So I don't try and convince people of what they do or don't have. I will say this, though, that many times presentations look like other presentations. And so in medicine, we do a lot in psychiatry and neurology, and in the practice of medicine as doctors. One of the things we do is we look for patterns, and there's pattern recognition. And whether it's depression or Parkinson's or panic disorder or functional neurological disorder. So many times, a lot of people look very similar based on that presentation.
Great, thank you.
So is there any new research that you are aware of about FND?
There is. I've told you about the Taking Control of Your Seizures workbook. We've actually, because patients might not only have seizures, they might have other types of presentations. So we actually have rewritten the workbook for those specific presentations. One example is taking control of your functional movement disorder. Another example is taking control of your functional cognitive disorder. Sometimes people who have a history of mild traumatic brain injury or a closed head injury, when they keep having symptoms over a year later, when most of the time symptoms resolve with mild TBI, if they continue having symptoms, that's called prolonged post-concussive symptoms. We found that many times that is associated with a history of post-traumatic stress disorder and other prior events. So we reworked and rewrote the workbook for taking control of your functional cognitive disorder to be able to address those symptoms. So at Rhode Island Hospital, we've just gotten approval for a pilot randomized control trial of neurobehavioral therapy using the functional motor disorder workbook. And, if people with this disorder and diagnosis confirmed want to reach out, they can call our research office at 401-444-5555, or they can email at neuroresearch@lifespan.org. And they can be screened to see if perhaps they could be enrolled in the treatment trial.
Thank you.
And can you define the terms you use, the functional neurocognitive disorder? Could you define what that would, tell our listeners what that would look like?
Sure. So cognition or cognitive is thinking, thoughts, and people who have, we talked about functional seizures.
Right.
And it might look like epilepsy. And we've talked about functional movement disorder, and it might look like Parkinson's. And with functional cognitive disorder, people have actually asked me, Doctor, do you think since that head injury, do you think I have dementia? So it might look like dementia.
Right.
But what we find is when we do testing, when we do cognitive testing with a neuropsychologist, a person with a PhD who tests your thinking and your attention and your memory, they actually find that with people with functional cognitive disorder, as compared to people who don't have it, they have high complaints about their memory. I don't remember anything, doctor. But then objectively on the test, their thinking is intact.
Right.
So we find that discrepancy, and that's an indicator for functional cognitive disorder. And now we have a workbook that might be able to help people.
Great.
Thank you, Dr. LaFrance. It was great to have you here. Now, a take-home message to bear in mind.
So we've learned that functional neurological disorders are very real conditions that can cause significant distress and impair functioning in those who suffer from them. By continuing to support research and education about FND, we can ensure that those affected receive the appropriate care and treatment that they deserve and need.
And as always, if you or a loved one is having suicidal thoughts, please contact the Suicide and Crisis Lifeline, call or text 988, or access 988lifeline.org. The Lifeline is a 24-hour toll-free phone line. You can also go to the nearest emergency room and ask for help.
Thank you for listening to our podcast. For more information related content, please check out our Instagram, X, Facebook, and YouTube channels. Bear in mind the Brown Psychiatry Podcast.